We move on to chapter 19, which is the knee. The knee joint has two motions, flexion and extension. Be sure to memorize these two range of motions as they will show up on quizzes and tests, etc. It is a synovial hinge joint. However, it is not a true hinge joint because it has a rotational component or an accessory motion. The femur is convex and the tibia is a concave. Here are some bony landmarks for the tibia. These all serve as attachments for different muscles. You will need to memorize the landmarks here for the tibia, and the only one for the fibula will be the fibular head, as it serves as an attachment point. The fibula is not part of the knee joint, and there's no articulation with the femur. It plays a much bigger role at the ankle, but we'll need to know it because of the fibular head as an attachment point. The patella is a triangular shaped sesamoid bone within the quadriceps muscle tendon. The function of the patella will be described later, but basically it changes the angle of the quadriceps tendon to resemble a pulley to increase the force of the quads. As mentioned before, the tibiofemoral joint is not a true hinge joint. It does have a rotational component, and this is what's called the screw home mechanism. It's because the medial femoral condyle is longer than the lateral condyle, and when you extend your knee or straighten it out, the articular surface of the lateral femoral condyle is used up while about a half inch remains medially. Therefore, the medial femoral condyle must glide posteriorly to use all of its articular surface. With the knee extension and non-weight bearing, you get external rotation of the tibia, as you can see from the picture there. Basically, the tibia rotates laterally in extension to lock in non-weight bearing, or open chained. To review open chain and closed kinetic chain definitions, it's page 49 and 50 of your textbook. The convex and concave surfaces lock together, and you do not have to use a lot of muscle control to stand on a locked knee. During weight-bearing activity, or a closed chain activity, the posterior glide of the femur results in the femur rotating medially on the tibia. The tibia fixed and the proximal component moves. That's what makes it a closed chain. And this all occurs in the last 20 degrees of extension. The patellofemoral joint, as you can see there, is the patella sitting right there on the femur. And how does it function? Well, it increases the mechanical advantage of the quadriceps muscle, and it protects the knee joint. As mentioned before, it changes it to a pulley and increases the advantage of the quads there. The vastus medialis obliterans, and we'll talk about this more later, can be strong enough to overpower certain other quads or quadriceps muscles. It can also be weaker, and that can cause the patella to come off track, which in turn can cause pain under the knee. The Q angle has a lot to do with that. The Q angle, or the patellofemoral angle, is formed in the frontal plane by two line segments. It goes from the tibial tubercle to the middle of the patella, from the middle of the patella to the ASIS. Those normal angle ranges between 13 and 18 degrees. The Q angle is greater in females because females have wider hips. This angle represents the quadriceps muscle force, and it's defined as the angle between the rectus femoris muscle and the patellar tendon. You can see that illustrated on the picture over here on your right. So this is the angle that we're looking at right here. Here's another picture, and as you see, if your hips were wider, that would move this point out, increasing the Q angle here. Here's another illustration between males and females. All right, so let's talk about what happens when the Q angle is not where it should be. If it's less than 13 degrees, it's associated with what's called chondromalacia patellae. In other words, that's basically irritation of the undersurface of the kneecap, irritation to the cartilage. Over time, as if that irritation continues to be there, you can damage the cartilage there. So it's a fancy word for patellar tracking. If the angle is greater than 18 degrees, it's associated with the same thing, that patellar tracking or damage to the, or irritation to the cartilage under the kneecap. It can also cause a subluxing or dislocation of the patella. It can cause what's called genu valgus. We'll talk more about that in a minute. And tibial torsion. This can also cause pain in other areas outside of the knee, including the hip, the low back, and the ankle. So genu valgus and genu varum are just the angles of the knees here. Genu varum is what's also known as bow legs. Genu valgum, which is also known as knock knees, and genu recurvatum, which is also known as back knees. These are associated, if you remember before, of coxa valgus and coxa varus. These are also associated with those as well. Coxa varus is associated with genu valgus or valgum, and coxa valgus or valgum is associated with genu varus or varum. All right, the tibiofemoral angle is what's used to describe the frontal alignment of the knee. Normal is about 165 to 180 degrees, again depending on male, female. Genu valgus occurs when the angle is less than 165 degrees, and that's associated with coxa varus, or the angle at the hip being less than 125 degrees. Genu varum is when the angle is greater than 180 degrees, and it's associated with coxa valgus, which is also greater than 180 degrees. Excuse me, that number is supposed to be greater than 125 degrees, right here. All right. Different bones and landmarks of the knee joint that you will need to memorize: femur, tibia, fibula, patella, and the calcaneus. First, we're going to talk about the ligaments associated with the knee. We'll start with the anterior and posterior cruciate ligaments, also known as the ACL and PCL. They're both located within the joint capsule, so they're intracapsular ligaments between the medial and lateral condyles. Cruciate meaning that they cross or resemble a cross. And they're named by their attachment on the tibia. That is very important to remember. So the anterior cruciate ligament, or the ACL, is named because its attachment on the tibia is where it starts. Both of these ligaments provide stability in the sagittal plane. Here's a good look at the ACL and PCL ligaments with associated structures. The picture on your right here is kind of a dumbed down picture so you can understand what they look like. This being the anterior side of the knee, and this being the posterior side. So as you can see, the ACL is on the anterior side of the tibia, and the PCL is on the posterior side of the tibia. So here's some more information about the ACL. It runs from anterior tibia to posterior femur. It attaches to the anterior surface of the tibia in the intercondylar area just medial to the medial meniscus, and runs superior and posterior, and then attaches posterior on the lateral condyle of the femur. The ACL prevents an anterior tibial displacement on the femur and a posterior displacement of the femur on the tibia, basically preventing the tibia moving forward and the femur moving backwards. The ACL is tight during extension, which is why most ACL tears occur is during extension and rotation, which we will talk about shortly. Here's a picture of a torn ACL and MCL, and we'll talk about the MCL in a little bit. So ACL running right through here, and you can see the tear right there. I've also put a video on Blackboard of a ACL reconstruction video that we will talk about further in class. Moving on to the PCL, it runs from the posterior tibia to the anterior femur, and it prevents posterior tibial displacement on the femur and anterior displacement of femur on the tibia. It is tight during flexion. Injury or tears specifically alone to this tendon are very uncommon, secondary to the knee being in flexion. If it does happen, it usually happens with other involvement to other structures. One example of a reason that maybe somebody can have a PCL tear or injury could be if they're in a car wreck because the knee is in flexion and the dash hits the anterior tibialis or anterior tibia. Alright, so here's some application questions here. So ACL and PCL. So since the ACL prevents anterior tibial displacement on the femur and posterior displacement on the femur on the tibia, and PCL does the opposite, let's look at this scenario. So a patient's foot is planted on the ground. They were hit by a force to their anterior femur, which pushes the femur posterior. Which cruciate ligament is most likely torn in this scenario? The ACL is most likely to be torn because with the foot planted on the ground, when the force hits the anterior femur and pushes it posteriorly, it will stretch the ACL as the femur moves posteriorly. Alright, moving on to the MCL. So these next two ligaments are going to be the provide lateral and medial stability here in the frontal plane. So the medial collateral ligament, or MCL, flat broad ligament, it attaches to the medial condyles of the femur and tibia, but also has an attachment to the medial meniscus. You're going to see associated injuries with this. We'll talk about this more in a second. But it protects against lateral stresses to the knee. The LCL is a round cord-like ligament, so a little different shape. Attaches to the lateral condyle of the femur and runs down to the head of the fibula. There is no attachment to the lateral menisci with this one. It's pretty strong ligament, and it's often seldom injured. Again, if it's injured, there's usually other associated structures that are also injured. But it protects against medial stresses. Alright, so both the MCL and the LCL provide stability in the frontal plane. Medial collateral ligament gives medial stability, prevents excess motion from blow force to the lateral side, and vice versa for the LCL. They're tight during extension and slack during flexion because of their attachments. And both ligaments are posterior to the knee axis. So to review, think about the motions that occur in the frontal plane. So MCL and LCL application. If a patient was standing or running and they were hit by force to the lateral aspect of the tibia with their foot planted, which collateral ligament would most likely be torn? Well, if they were hit from the lateral aspect, it would cause stress to the medial aspect. That's a good chance that their MCL could be torn or injured because of this, because of it's put on the stretch, because of the force. Here's another view of the knee joint, kind of a superior view here with the associated structures. Let's talk a little bit more about letter G there and letter D. So the menisci are two half-moon wedge-shaped fibrocartilage discs that do not have a blood supply. Their location is the superior surface of the tibia and their purpose is shock absorption and to deepen the joint surface. They're thicker laterally, thinner medially, and the proximal surfaces are concave. To go back to the point where they do not have a blood supply, if you injure a meniscus, it is not easily healed on its own because of the lack of blood supply. The medial meniscus is torn more frequently because of its attachment to the MCL. However, the lateral meniscus can also be injured pretty frequently as well. Here's a picture of all of the ligaments we just discussed. So you have the ACL running here, PCL coming from the posterior side, MCL, and LCL. A good way to identify whether this is a right knee, left knee, anterior, posterior view is if you look at the fibula is on the lateral side always. So anything on the opposite is medial, anything on the same side is always lateral. Here's a different view of it. You will also have a copy of this picture to your right as practice for you to label on. You can find that on Blackboard. Alright, so the knee joint itself has several different bursa. Basically, these bursa are small pod-like sacs located in areas of excessive friction, under tendons, and over bony landmarks. Repeated motions can cause excessive wearing of the bursa and can cause irritation of the bursa as well. And I'll show you a picture of that in just a second. You have a suprapatellar, a prepatellar, a deep infrapatellar, and you can kind of see where they would glide and rub. So if the bursa gets irritated because of too much friction, you can get what's called bursitis. This is an example of prepatellar bursitis. And it's kind of caused by that constant pressure between the skin and the patella. This one in particular is very common with people who work on their knees, carpet, tile, or have a result of direct blows or shearing stresses on the knee. Alright, moving on the posterior aspect of the knee, we have what's called the popliteal space. It contains nerves and blood vessels, including the tibial nerve, the common peroneal nerve, and the popliteal artery and vein. It's a diamond-shaped fossa, and it has the borders consist of some of the hamstrings and the gastroc. When you cause pressure in this space, for example, when you cross your legs, you actually can pinch nerves and blood vessels, and this is what causes your foot to fall asleep sometimes. The pes anserine is what's also known as the goose foot. It's a muscle group consisting of the sartorius, gracilis, and semitendinosus. And each has a different proximal attachment. The sartorius is the iliac spine, the gracilis is the pubis, and the semitendinosus is the ischial tuberosity. These all cross the knee posteriorly and medially and have that common distal attachment, as you can see on the picture. Another picture that you can see this on is page 275, figure 18.29 in your textbook. Alright, we're moving on to the muscles of the knee. Again, to reiterate this, you need to memorize the origin, insertion, action, and nerve innervation for each one of these muscles. I will give you common characteristics and different notes about each muscle as I see. The rectus femoris is a two-joint muscle like we discussed back at the hip. Crosses the hip and the knee and has both actions at both of those joints there. To review active insufficiency and passive insufficiency, You can go back to page 43 in your textbook. For the rectus femoris, I want you to think about what would put it in passive insufficiency. The answer is it would be stretched across both the hip and the knee, resulting in passive insufficiency with the hip extended and the knee flexed. To flip that around, how would we put the rectus femoris in active insufficiency? Well, the hip would have to be in flexion and the knee would have to be in extension, which shortens the muscle as much as it can go. The vastus lateralis is the lateral aspect of the quads, while the medialis is the middle, and intermedialis is on the medial side, thus completing the quadriceps group. To go back to the vastus medialis, the part right in this region, kind of where that line is pointing to, the muscle's further broken down into what's called the VMO, or the vastus medialis obliterans, and it has a pretty big effect on what happens here at the kneecap, as I mentioned before. You won't be tested on that, but know that it has a pretty good power or importance on the kneecap itself and the direct firing of these quad muscles. Especially after a total knee replacement or ACL reconstruction, that VMO is usually very weak, and we sometimes have to use other forces to help get it stronger. Alright, so the hamstrings, again, are another group that run on posterior thigh muscles. They are two joint muscle as well. You have the semitendinosus biceps femoris, the long head and the short head, and the semimembranosus. Their common origin is the ischial tuberosity. Quick note about the hamstrings is they're notorious for being tight. Well, why do we even care about that? Well, tight hamstrings can cause things like low back pain, knee pain, hip pain, and even ankle pain sometimes. They can lead to a muscle imbalance, which can also disrupt other functions in the hips, knees, and ankles. All right, popliteus muscle is deep to the two heads of the gastrocnemius, and basically its function is unlocking the knee or initiating knee flexion. The gastrocnemius muscle is also a two-joint muscle. It crosses the knee and the ankle. We will talk about the ankle functions later in the next chapter. Important note about the gastrocnemius muscle is as a knee extensor with non-functioning quadriceps. Stance is possible by gluteus maximus, which does hip extension, and the gastrocnemius action. In a weight-bearing position, such as standing on your feet like the picture shows, the two muscles contract, which can pull the knee into extension. The soleus, behind the gastroc, as you see there labeled with the S, may assist that gastroc. So you can see the glute pulls the femur into hip extension, and the gastroc can pull the knee and the femur into extension as well. So other muscles of the knee joint, the gracilis, sartorius, and TFL, span the knee posteriorly. They provide stability to the knee but do not have a prime function. You can see there on your right what other muscles here do. So your prime movers of the knee, there's your extension, it's your quadriceps group, and your flexion, which is your hamstring group, popliteus, and the gastroc. Here's a summary of the nerve innervation of the knee muscles as well. Again, reminder, at the end of the chapter, there's always a table that will have these prime movers and the nerve innervations to help you study and memorize these. Thus concludes